So today's our topic is Brunnstrom approach. Okay. So I think everyone is aware about that. Brunnstrom approach કદાચ તમે નામ સાંભળ્યું હશે maybe. Okay. Brunnstrom approach 1956. Okay. She was discovered by one clinical scientist. Okay, that was a girl. Okay, who identified this Brunnstrom approach 1956. She was a physiotherapist plus clinical scientist. Okay, and she developed the Brunnstrom approach. આ સૌથી જૂનો અપ્રોચ છે. આ અપ્રોચ પ્રમાણે ટ્રીટમેન્ટ આપવાથી પહેલા શરૂઆત હતી, પછી એના પછી ધીરે ધીરે રૂલ્સ આવ્યું, બોબાથ આવ્યા, અને પછી છેલ્લે એનડીટી આવ્યું, સેન્સ ઇન્ટિગ્રેશન્સ આવ્યું, ડિફરન્ટ અપ્રોચીસ પછી આવવા માંડ્યા. તો આ સૌથી જૂનો અપ્રોચ છે. Actually, at present, if you go in neurophysiotherapy, there is no particular approach, okay, on which you can give the guarantee of the treatment. કે આનાથી પેશન્ટ હેમિપેજિક નું સારું થશે કે સીપી નું સારું થશે. Okay, we cannot give guarantee. We have to use multiple approach, or we have to use different approaches when the different patient comes at a different stage of the recovery. કદાચ બને કે અમુક જગ્યા સ્ટેજમાં recovery અટકી ગઈ છે, we have to use Brunnstrom approach. Sometimes you have to use Bobath approach. Sometimes you have to use roots approach for some movements. So you can use multiple approach at a time to give the functional recovery to the patient. Main આપણું criteria એ જ હોય છે કે patients ને functional recovery આપવાનું. Okay, દરેક approach ના થોડા drawbacks છે, થોડા advantages પણ છે. Therefore we are using the multiple approaches, right? Because of that reason. So this is a Brunnstrom approach. Okay, તમને આ બધાને I think શેર થઈ ગયું છે, તો તમને આ સ્લાઇડ દેખાશે. Okay, it is handwritten materials first. Okay, then we go to the PPT. Okay, it is developed by the approach by trial and error fashion. અમને એવું હતું કે Brunnstrom જે physiotherapist છે, she was using this approach. She was trying to applying using the reflexes which is present in the hemiplegic patients and associated primitive movements, associated reactions. Okay, all he was already available in the hemiplegic patient. She was trying to use that available reflexes and available associated reaction, available primitive reflexes, okay, in order to gain the movement. And she was succeeding in that. Then she developed this approach. Okay, and in that it is depends on that only. You're using the available abnormal reflexes, okay, and making the movement, okay, and facilitating the movement for the next stage to improve the spasticity. And the spasticity produces movements. Then you have to solve that spasticity does not go beyond the movement, okay, and then start giving the movement in such a way that spasticity reduces and the movements improves. And finally the patient reaches to that particular part where the spasticity is the minimum and the movement is the maximum. This is a basic introduction about this approach. Okay, so in that, reflexive and primitive movement patterns, okay, should be used to facilitate the recovery of the voluntary function. This is the main part of this. Okay, reflexive and primitive movement patterns should be used to facilitate recovery of voluntary function. એક સેન્ટેન્સમાં ખબર પડી ગઈ, this is what is called Brunnstrom approach. One sentence માં પૂછે તો this is the one sentence. Reflexes means whatever reflexes are available in the patient, abnormal reflexes like ATNR, STNR, TLR, tonic labial reflex, tonic lumbar reflex, all the reflexes, and primitive movement patterns like synergy patterns, okay, flexion or extension or hemiplegic synergy patterns, right, that all used to facilitate the recovery of the voluntary function. Okay, that is the main purpose of this Brunnstrom approach. Okay, what are the principles of the Brunnstrom approach? Treatment progress આવી રીતે થાય. First we have to use the available reflexes. We have to convert them into the voluntary movements, okay, and then convert it into the functional movements. That is the main treatment progression criteria of this Brunnstrom approach. This is a pattern. How? Second point is the movement. How it can be facilitated? Movement can be facilitated by either using the reflexes, or I also told you about either using the associated reactions or using the proprioceptive or exteroceptive facilitations. We can use any of these four things to facilitate the movements. By the initial stage, you know, there will be the less tone, decrease in a tone. There may be the facility. So how to gain the movement from the facility in the hemiplegic patient upper limb and as well as lower limb? This is by using either reflexes, associated reaction, proprioceptive or exteroceptive facilitations. We can give the different type of facilitations. Where we go to all these details. Okay. The third point, when the voluntary effort produced, okay, after giving the movement started initiate the movements voluntary without support. Patient is asked to do first is isometric contractions within the available range and strength of the particular muscles. Second is isotonic in the eccentric way, okay, to gain the stability of that same muscles. And then lastly, we do the patient's concentric exercise of the same muscles or the same movements. Okay, this is the way how you progress in this Brunnstrom approach. First, when the voluntary movements happens by using the reflexes, there may be the minimum voluntary movements. Okay, then also start doing the isometric movement exercise of the particular available voluntary movement muscle. Then eccentric exercise, isotonic in eccentric way of the same muscles, okay, in opposite direction, and then tell the patient to do the same movement in concentric manner. Okay. And fourth point, when even only partial movement is possible, reverse of the movement from flexion to extension is traced within the each session. What does mean? When even only partial movement, it means when there is no total full shoulder flexion. It's only initiate. Okay, it only initiate from the shoulder. Okay, either in shoulder elevation or shoulder abduction. When just initiating the movement, okay, the partial movement is possible. Then what you have to do? We have to also train from the same position. You have to train from the reverse movement. Means shoulder elevation and abduction. If it is available as a partial movement, then you have to at least try to elicit the shoulder depression and adduction. Okay, so you have to go from the opposite movement. Okay, when the one partial movement is available, try to develop the opposite movements. It is a flexion, try to develop the extension. It is extension, try to develop the flexion. Right? That is means in the 4th point. The 5th point, facilitation is reduced as quickly as patient shows evidence of the voluntary control. You have to give facilitation, you have to use the reflexes, ATNR, STNR, that I am going to tell you in detail. Okay, but once the movement is possible, okay, without reflex, patient is able to do the voluntary movements, then stop giving the facilitation in the form of the reflexes. Okay, in the form of the any of the 4 way what we told you before. Reflexes, associated reaction, extroceptive or proprioceptive facilitation. You have to stop giving the facilitation when the voluntary movements starts. 5th point, emphasis is placed on wheel movement. Wheel movement means voluntary movements. Means patient wants to lift some glass, want to do some movement, want to take the hand to the mouth. Patient has to will. He has to wish to I want to do this movement. Okay, so we have to encourage him. You please try to give a command from the brain and try to initiate the movement, try to perform the movement. Active participation of the patient is very, very important in this. That is called emphasis on wheel movement. 7th point, once correct movement is produced, then practice the same movement for learning. It's very, very important in the neurophysiotherapy. You have to do practice. There's where the main patients will lacking in that part. We do the treatment over here. Whenever we spend time for them, we tell them to produce in a similar way what we have learned, but they don't do the practice at home enough sufficient, then the movement is delayed. So the patient have to come years to years for the same movements. Okay, that is when the correct movement is learned. They learn this movement. Okay, you have to do this movement without using this abnormality. Once learn the movement in the particular proper way, then you have to practice the movement same again and again till it becomes perfect. Okay, for the learning, right? So this is 7 points, okay, that I told you. Okay, you have to remember for that. Okay, it's very important for the Brunnstrom approach treatment protocol. Okay, fine. So I told you that all 7 points. Okay, first after okay, reflex voluntary the functionality movement progress treatment progress movement can be facilitated by the reflex, associated reaction, proprioceptive, extroceptive તમને ખ્યાલ આવી ગયો. Voluntary movements one produce the isometric, you have to go to isotonic and concentric. Okay, once it started in the one direction, we have to immediately have to start within the available range to the opposite direction. Is quickly once you have to leave the response when the facilitation is, we have to reduce when the voluntary movement happens. Emphasis may be on the wheel movements. Okay, and when the correct movements learned, we have to repeatedly do it again and again for learning the perfect movements. Right? Okay. We can also have to develop with the associated reaction. Okay. In the same point, okay, we have to use the tonic reflex. Associated reaction can be used to produce the movement. Okay, which are tonic reflexes, what are associated reactions, that we go in detail. Okay, proprioceptive exercise also can be used to produce the movement. Okay, that we already discussed. Recovery progress from stereotype flexor extensor pattern. Okay, recovery always process by using this all facility techniques, stereotype of flexor or extensor patterns. Okay, or it may be combination of the both the patterns. Okay, and then later on patient develops the voluntary movements. Okay, for that you must know what is a flexor pattern, what you should know what is extensor pattern. Okay, patient always uses the combination of the both. Okay, very few patients you find that there is a proper exactly flexor synergy pattern or exactly extensor synergy pattern. Hemiplegic have the patient will have the mixed pattern. Okay, and out of the mixed pattern patient learns slowly, that is a voluntary movements. Okay, current movement pattern must be practiced to be learned. If you are drawing the practice of the wrong movements, we will rapidly learn the wrong exercises. Wrong patterns will be developed in the patient. Practice within the context of the daily activity. And they have to use that movement in daily functional activity. It's not like you have to use this. Okay, do this. This is not the movement. You have to try to reach some graphs. You have to try to reach some hands, some for functional activity. You have to try to give some task for that particular activity. Okay, that it becomes converted to the functional. It's not doing the single movements. You do the practice of the movement. We have to convert it into some functional. You have to use it in daily activity. You have to convert it, right? So stages. Then next we go to stages of the recovery of the upper extremity. Okay, Brunnstrom has the 7 stages. Okay, of the recovery of the upper extremity. Okay, it has a 7 stages. So when you take the assessment of the patient, you have to take the assessment of the patient in the Brunnstrom pattern. Okay, then you have to give the what the your patient in which stage. So you have to go to all the 7 stages, and then you have to mark okay, my patient is available in this stage 7, stage 6, or it is still in the stage 1. Okay, so what are the stages of the recovery of the upper extremity as according to the Brunnstrom? It's very useful when you take the assessment of any hemiplegic patient. Stage 1 is a flaccidity, no voluntary movement. Stage 2, synergy starts just developing. Flexor usually develops before the extensors, and spasticity developing. Okay, like a second stage where the synergy initiate to develop. Okay, flexor will develop first. Stage 3, beginning voluntary movement but only in synergy. Okay, increasing the spasticity. Third stage, spasticity increases. So voluntary movement will increase, but it will increase in synergy pattern. Right. Stage 4, some movement deviating from the synergy. From the stage 4 onwards, okay, spasticity start declining. Okay, so you find some movement which is out of synergy, not full movement. Some movement will start out of synergy, that you can understand now spasticity is not increasing because limb is moving out of synergy. Okay, then you can tell is it is stage 4. Stage 5, independent movement from the basic synergy. Spasticity is still decreasing. Okay, you are getting the independent movement. Still spasticity decreasing, you are moving away from the synergy patterns. Initially, there was some component of the synergy pattern which was deviated. Now, more than 50% components are deviated now. Okay, out of synergy. It means it is spasticity is decreasing. Right. Stage 6, individual joint movements is also able to perform freely. That is causes minimum spasticity. In spasticity, you know, whenever patient tries to move the limb, it moves the limb all joints together, not able to move the individual joint movement. Okay, once the individual joint movements happens, it means spasticity has reduced so much. It's not group of the muscles are spastic now. Okay, very few muscles are spastic now. Slowly reducing the joint spasticity, and now individual joints movements is possible. Therefore, there's a minimum to minimum means less than 10% of the spasticity is available. Then only it is possible isolated joint movements, right? And 7th stage, it is a normal, means no spasticity. Or individual joints able to perform, individual muscles able to perform. Okay, there will be coordinated ADL activities will be able to do by the patient. Okay, that's the normal voluntary control. That is called stage 7. Right? These are the important stages of the Brunnstrom. Okay, 7 stages. I think done a till 3rd stage is spasticity increasing, 4 stages onwards, spasticity decreasing from small component to major component to lastly to the individual joints. Okay, and lastly is the 7th is the normal. Okay, fine. What are tonic reflexes? Tonic reflexes, we told you that we have to use the tonic reflexes as a pattern of facilitation to improve the muscle tone. from the facet to gain the wanted movements. So how to use the tonic reflex? Which are tonic reflexes? As an early treatment, reflexes can be used. Okay, I told you we have to use the reflexes first, then there are the associated reactions, then extroceptive and proprioceptive facilitation techniques. Okay, that can be used. That we have to use for the patients. Okay, so what are tonic reflexes? Initial stages we have to use the tonic reflexes. Okay, that is first is the ATNR, asymmetrical tonic neck reflex. Second, symmetrical tonic neck reflex. Third is the tonic labyrinthine reflex. Fourth is the tonic lumbar reflex. Right? આ ચાર reflex તમને ખબર બી હશે, નહીં ખબર તો હમણાં તમને આનો PPTs બતાવું છું. Okay, asymmetrical tonic neck reflex. Okay, like this. Symmetrical tonic neck reflex, tonic labyrinthine reflex, and tonic lumbar यानी rotational reflex. Okay, ये चार reflex તમને હમણાં આગળ PPT માં ફોટોગ્રાફ સાથે બતાવું. Okay, આ બધા reflex માં શું થાય છે? When increase in upper left extremity tone, increase in lower extremity tone. Okay, and also towards the side, towards the trunk is rotated. જે બાજુ trunk rotate થશે એ બાજુનો upper extremity tone વધે છે, lower extremity નો extensor tone વધે છે. trunk આ બાજુ rotate થશે તો એ બાજુનો upper extremity tone વધશે and same side no lower extremity no extensor tone was, right? This happens in normally all the reflexes. Second is the associated reactions. Okay, that is second point. We have to facilitate, use this technique to facilitate a tone out of the going to patient, make the patient out of flaccidity. The second is the associated reaction. So what are the associated reactions? They are seen in the inward extremity of the stroke patient when other parts of the body can be resisted during the movement. For example, my right side is hemiplegic, left side is normal. If I'm giving the resistance to my normal side, any resistance to any direction, flexor resistance, extensor resistance, abductor resistance, adductor resistance, any direction I'm giving resistance to the unaffected side, okay, it moves the movement on the affected side. It produces the movement on the affected side. Okay, that is called associated reactions. More easily elicit if the spasticity is present. When this associated reaction present, there is a spasticity, then only associated reaction will be present. Okay, then only this is the way by use. Okay, by using the unaffected side, you produce a movement in affected side. There is a treatment protocol in this associated reactions in Brunnstrom. First point is A, flexor synergy, right? Flexor synergy is in the involved upper extremity, is elicited by apparent resistance to shoulder elevation or elbow flexion. If you give the resistance to elbow flexion or shoulder elevation, it gives the movement on this affected side. Okay, this is called the flexor synergy. How you can develop extensor synergy also can be elicited by the same opposite direction. Elicited by applying resistance to the horizontal abduction of the uninvolved upper extremity. Horizontal adduction matlab resistance આપો છો, it produces extension on the affected side. Right? This is the way how you produce the extensor synergy. There is a Ramage phenomena. Okay, what is Ramage phenomena? When you give the resistance to the hip abduction or adduction in the uninvolved lower extremity, which produce the same response of hip abduction or adduction, okay, in the involved side. Okay, that is called Ramage phenomena. Ramage phenomena matlab hip abduction में resistance आपको तो adduction में resistance आपको on involved side, it produce the same movement, have to produce the same movement or same muscle contraction on the involved side, right? That is called Ramage phenomena. Okay, this is also part of this associated reactions. Resistance to the flexion of the uninvolved leg, resistance to flexion of the uninvolved leg, lower leg, causes the extension of the involved leg, opposite direction. Right? I'm giving resistance to my hip flexors of the my left side. I told you is normal, right side is hemiplegic. So when I'm giving the resistance to the left side of hip flexion, it produces the right side of hip extension. For that, you have to place the right hip in flexion at a starting position. Right? Your right hip should be in flexion as a starting position. Okay, then you have to give and left right side it will be in flexion, hip knee flexion, and left side of hip knee in extension. When you give the resistance to the left side of hip knee flexion resistance, it produces the which was already in flexion, it will produce the extension movement of the hip and knee on the affected side. Okay, that is called. This is also part of this associated reaction. Right. Next is the resistance of grasp of the uninvolved side. Okay, this is a uninvolved side, normal. Okay, if a resistance resisting this part, okay, on the uninvolved side, Okay, for example, I'm resisting. Okay, I told you to grasp this napkin. Okay, and produce the resisted grasping of the finger flexion on the uninvolved side. When I'm doing this movement, you automatically produce a grasp reflex on the involved side. Okay, that is used to produce a grasp in the affected side. Okay, fine. So this is the part of this associated reaction. How to use the associated reaction, right? So we first discuss about the reflexes. Okay, what are reflexes we have to use? Second is the associated reaction. How to use the associated reaction for producing the movement on the opposite side, means affected side. Okay, in hemiplegic patient, okay, you have the two limb synergies. Okay, for that you have to must know about the synergies. Okay, which are the synergies are present, or which are the synergies? Okay, that is called flexor synergy or the extensor synergy. I told you the minimum patient will have the flexor synergy. Okay, in hemiplegic patient. Okay, and the minimum patient will have the proper extensor synergy in the hemiplegic patient. Right. Okay. So what is the flexor synergy? Okay, flexor synergy, it is scapula is in a retraction. Okay, and elevation. Fine. Retraction and elevation. Flexion. Shoulder in abduction and external rotation. Forearm in supination. Finger in flexion. Elbow flexion. Forearm supination. Wrist and a finger in flexion. Okay, that is called flexor synergy. Okay, whereas in extensor synergy, okay, it is shoulder in protraction, depression, adduction, internal rotation, elbow extension, forearm pronation, wrist, okay, extension, and finger flexion or extension. It may be flexion or extension. Okay, that is extensor synergy. Now you know, no hemiplegic patient will have this synergy. Hemiplegic patient will have the mixed synergy. Okay, what is a mixed synergy? The strong component of the both the synergies, okay, act together and produce a typical posture in hemiplegic patient, because you find minimum hemiplegic patient in this position, okay, or minimum patient in this position. Okay, no patient will find in this position. Minimum patient, very few patient will find in this synergy. Okay, they mostly have this pattern. Okay, so what is this pattern? It is a combination of the both the synergy. Right, that is called stronger component of the both the synergies. Okay, produce a typical posture of the hemiplegic. Okay, that is his shoulder adduction,